All right, guys, let's get busy talking about our disorders of sexual development, also called DSDs. We're going to have our master diagram again here, and I want to talk about how we're going to approach today's lesson. So in all of our round bullet points here, we're going to be discussing important pathophysiology, and then we're going to go through each of these square bullets, and each of these square bullets are going to be a physical exam finding or a structure, and we're going to discuss the embryological time points and the actions that lead to the presence or absence or function or non-function of these parts respectively. I want to start out by talking about 5-alpha reductase deficiency. Now, if you remember, 5-alpha reductase is going to be an important enzyme, and it's going to exist down here in our diagram, and its job is to convert testosterone to dihydrotestosterone, also called DHT. So if we have this enzyme not working properly, we're going to get failure of testosterone to convert to DHT. This means we're going to have increased levels of testosterone because it's not getting converted. And we're going to have decreased levels of dihydrotestosterone because there's none of it coming from testosterone. Now, if you remember, DHT has a really important role in developing the sexual characteristics of males with XY chromosomes. So what happens with DHT is responsible for the development of the external genitalia. And so when our DHT is absent, this is going to lead to ambiguous male genitalia. So let's go ahead and review here. We're having a decreased conversion of testosterone because 5-alpha reductase is not working. And so our DHT is going to be decreased. And then we're going to have ambiguous genitalia because the genitalia rely on DHT in order to show the male phenotype. So this is a great opportunity for us to review some of our genital embryology. We're going to have absence of phallus elongation. And you'll remember that the phallus elongation is going to occur at the genital tubercle. And I'm going to highlight this for you guys here in this red area. This is the area of the phallus that extends from the genital tubercle. Moving on now to our next structure, we're going to have a bifid scrotum. And you'll remember that this is due to improper development of the labioscrotal swelling. I'm going to go ahead and highlight this in our diagram here, which is going to be this area down here. And because of this happening, we're going to get this bifid appearing scrotum, which is going to look like it kind of has two pieces. So it's going to kind of look like this, whereas normally it should look as one uniform pouch. Next, we're going to have hypospadias. And hypospadias, if you remember from a previous video, is going to be a hole where the urethra is popping out of the penis on the ventral side. And this is because we have failure of the urogenital fold here in this case. And I'm going to go ahead and highlight this area in bold here. And then it's also important to remember that DHT is going to be responsible for proper development of the prostate, but the prostate is not an external structure, so this will not be seen on physical exam, but I still wanted you guys to know this. And then it's important to note that these symptoms are going to last until puberty. So we're going to have these ambiguous genitalia until puberty, at which point testosterone levels will really ramp up, and the testosterone is going to be enough to start changing some of these external genitalia. Whereas in the beginning, we needed DHT because DHT is like mega potent, so just a small amount of DHT is enough during development to cause these male external genitalia to form. In terms of our lab workup, we're going to see that the testosterone to DHT ratio is greater than 20, and this makes sense because if you remember here, we have increased levels of testosterone and decreased levels of DHT, and this is because 5-alpha reductase isn't working, and that's how we get this ratio of greater than 20. And just to review, we are dealing with people with an XY karyotype, and they're also going to have normal estrogen levels here because there is nothing affecting estrogen. We actually have normal levels of testosterone at baseline, and so there's not an excess of testosterone that's being converted into estrogen. It's just that our ratio of testosterone to DHT is off in these patients. I want to quickly mention that this is going to be an autosomal recessive condition. Sometimes they like to ask about genetics on test day, and I want to have you guys covered there. Let's move on now to talk about androgen insensitivity syndrome, and I think this is a very complicated disease process, and it covers just about every portion of our diagram. So I think if you can understand this pathology, you have a really good grasp on our genital embryology diagram. So let's go ahead and get into it. We're going to have XY karyotype in these individuals. However, what is happening here in terms of pathology is that we're going to have a defect in our androgen receptor, making it insensitive to androgens. So when we think of androgens, we're going to think of things like testosterone. So here, if I was to draw a little androgen receptor like here, and then we have testosterone, which I'm going to represent with a T. Basically, the testosterone cannot act here on this receptor because it is genetically modified into a way that it can no longer interact with testosterone. It is important to note, however, that these patients are XY, so they have a Y chromosome. And we know that our Y chromosome has the SRY gene, which is going to produce testes determining factor. So these patients will go on to grow testes just fine. And we know that testes are going to be composed of Leydig cells and Sertoli cells. So to kind of orient ourselves in our diagram here, our undifferentiated gonad went to testes because we had a Y chromosome that was expressing testes determining factor. So we got testes, and therefore we're going to have Leydig cells and we're going to have Sertoli cells. And those cells inherently have nothing wrong with them. So our Leydig cells are indeed producing testosterone, and our Sertoli cells are going to make anti-Müllerian hormone just fine. So let's talk a little bit about what happens in these two situations. So since we have production of anti-Müllerian hormone, it's going to come over here and it's going to cause regression of our paramesonephric ducts. And because we have no paramesonephric ducts, we are not going to develop structures like an oviduct, a uterus, or an upper vagina. And that's going to be important a little bit later. Now, also, we will have no mesonephric ducts. And this is because the mesonephric ducts are under the control of testosterone. This testosterone is unable to have effect on the mesonephric ducts. It cannot support them because that receptor, which we talked about earlier here, is not working. Therefore, the mesonephric ducts do not get the hormonal support that they need, and they're going to regress. Therefore, we have no mesonephric ducts and no mesonephric duct structures in these individuals. Let's talk a little bit about how this presentation is going to occur. We're going to work our way through our square bullets and explain each one of them. So these patients are usually female presenting, and this is because they don't have the effect of any strong androgens like testosterone. So they're not going to get any heavy masculinization that we would expect with testosterone agonism. Next, let's talk about the fact that they have a rudimentary vagina. So if we look down here, when we talked about the fact that the paramesonephric ducts are going to regress, because we had formation of anti-Mullerian hormone, that means that our upper vagina is not going to be forming. And so the rudimentary vagina is just the fact that they don't have a mature upper vagina. Additionally, we're going to see primary amenorrhea. And why is this? Well, in order to have a menstrual cycle, you need to have a uterus. And if we look at our diagram here with the AMH leading to absence of paramesonephric ducts, we're not going to have a uterus. So in order to have a menstrual cycle, you need to have a uterus. These patients are not capable of having a menstrual cycle. Next on our list is going to be cryptorchidism. And why is it that these patients get cryptorchidism? And the reason here is because our testes are reliant on testosterone in their migration from the retroperitoneum down into the scrotal sac. And so if this migration does not occur, you're going to have testes somewhere in the retroperitoneum. Sometimes they can be found in the labial folds. They're not going to be in the correct position. And it's important that these patients get treated with orchiopexy because remember, anytime we have testes that are not in the scrotum, they are at risk for developing into cancer. Next on our list is going to be our absence of mesonephric duct structures. And why is this happening? Well, we know that the mesonephric duct is heavily reliant on testosterone in order to stick around. And since we talked about the fact that our testosterone cannot act on our mesonephric ducts, we are not going to be able to support these structures. So these patients will not have any of the structures we classically associate with the mnemonic seed. Let's move on to talking about our breast development. So these patients are usually going to have some degree of breast development. And this is because there is no effect from testosterone. So we have an imbalance of the effects of estrogen and testosterone. So the estrogen that is present in these patients is going to go ahead and encourage breast development here. And we're not going to have any testosterone to counteract it. Lastly, let's talk about our absence of pubic hairs. So we know that it's going to be androgens that lead to the development of pubic hair. And this condition is all about androgen insensitivity. That receptor cannot respond to those androgens. Therefore, these patients will have very sparse or very little pubic hair, if any at all. In terms of diagnostic workup here, we're going to have a karyotype that is XY, and then we're going to have increased levels of luteinizing hormone as well as increased levels of testosterone and increased levels of estrogen. Now, why is it that we have increased luteinizing hormone? And it's because the receptors responsible for sensing testosterone in the pituitary are not working. So the pituitary cannot sense that there are extreme levels of testosterone around. And so it keeps pushing more and more luteinizing hormone in order to try and get up from the absence of testosterone that it thinks it's experiencing. And why increase estrogen? Well, the change of testosterone into estrogen that occurs throughout the body has not stopped happening. So we have an excess of testosterone, and this is going to switch over to be converted into estrogen. And this is what allows us to develop things like breasts in these patients. Let's wrap up by mentioning that this is X-linked recessive in case we get some genetics questions on our exam. And then let's do a quick high yield review. Remember, in terms of 5-alpha reductase deficiency, it is all about DHT, and DHT is going to be responsible for development of the external male genitalia. And so we're going to have errors in that development. It's important to know these important embryological structures and also know that upon puberty, things will start to change when we get that big boost in testosterone. Moving on to androgen insensitivity syndrome, remember, we are also going to have an XY karyotype here. It's all about a defective receptor and its inability to sense testosterone. This is going to lead to failure of maintenance of the mesonephric ducts. However, we still have all the normal structures of the testes, so our production of AMH is going to lead to regression of the paramesonephric ducts and all of the associated structures. This is going to lead to things like primary amenorrhea, as well as a rudimentary vagina. However, the excess of testosterone in these patients is going to be present. However, it will not have any effect. So we do not expect these people to have pubic hair. And additionally, that testosterone is going to spill over into estrogen, which is going to lead to things like female breast development. It's important to know that this is going to be X-linked recessive. And then, as always, always refer to our diagram because it's going to guide all of our thought processes and allow you to get third order questions right when it comes to embryology on the exam. All right, guys, let's get busy talking about our disorders of sexual development, part two. This is going to be very similar to question. We're going to be talking about all these round bullet points, which is going to be the pathophysiology of the disease processes. And then these square bullet points, we're going to discuss why these phenotypic results occur. So we're going to be using our master diagram, which you guys are becoming good friends with at this point, to explain all of these changes. So go ahead and stay tuned and let's get busy. Let's start off by talking about placental aromatase deficiency. And this is exactly what it sounds like. We are lacking the enzyme aromatase. This is going to be an autosomal recessive condition in which our aromatase enzyme is absent. So let's go ahead and refresh ourselves as where aromatase exists in our overarching diagram. So you'll see aromatase is here, which I am highlighting in brown, and its job is to convert androgens into estrogens in the developing fetus. And this is going to be an important function because we produce some degree of androgens, and there's an important balance between estrogen and androgens, and we need to make sure that balance is staying intact. However, if this aromatase enzyme is absent, we are going to get increased levels of androgens. And at the same time, we will be getting decreased levels of estrogen because there is no androgens being converted to estrogens. They're just all staying as androgens. So that's the basic pathophysiology of what happens here. It's pretty simple right down there in the bottom corner of the diagram. So let's review. It's the inability to convert androgens into estrogens. So we're going to get increased androgens. Now, what happens when we have increased androgens? We know that androgens are responsible for masculinization in terms of the developing fetus and also during puberty. And so we're going to get fetal masculinization. So let's talk about what happens when we have fetal masculinization. So we know in our review from previous videos that estrogen is responsible for the female development of the external genitalia. And we also know that it was DHT, which is a very potent androgen that is responsible for the external male genitalia. So you're going to see we have a fundamental imbalance here. We have increase in this andronergic activity, and we have a decrease in this estronergic activity. So we're going to get very significant masculinization of this fetus's external genitalia. And in most cases, in most question vignettes, they're going to give you a newborn with an XX genotype. And this is important because this XX genotype, we would expect to have female external genitalia. However, this XX genotype baby is going to have masculinization or perhaps ambiguous genitalia, and that's going to lead to a workup. And so this workup is going to involve some further questioning. One part of these questions that really pops out is they will usually mention mom. And so the increased androgens in the fetus actually are going to spill over into the mother. And so you're going to get maternal masculinization as well. So mom will present with things like acne and facial hair and maybe deepening of the voice. And then our infant is going to have the ambiguous genitalia like we previously talked about. Additionally, as this child grows up, they're still not going to have aromatase. So they're still going to have that fundamental imbalance of androgens and estrogens. And this is going to lead to them having primary amenorrhea. Because let's do a review of what we need estrogen for. We know that we have low estrogen in these patients. So they're going to be unable to do all the things that estrogen is normally responsible for. So they're going to have no breast development. They're going to have absence of normal female fat patterns. So they may have like a very skinny build without female appearing hips. And they're also going to be unable to carry out menses. In terms of our lab values, we're going to expect to see decreased estrogen and increased testosterone. And this makes sense if we think about the fundamental imbalance that's occurring here because of our lack of aromatase. Now, I want to do some important differential building for you guys here because there are other conditions in which we get masculinization of the infant. And one that's important to talk about is congenital adrenal hyperplasia. Now, this is a variety of disease processes which we're not going to get deep into, but essentially there is faulty shunting of steroid precursors. So we know that steroid precursors go on to make a variety of molecules. Some that we want to mention are things like androgens and estrogens and aldosterone and cortisol. And so what happens is we can get differential shunting of these molecules in congenital adrenal hyperplasia. One specifically is called 21 hydroxylase deficiency. And this is going to cause an increase in androgens because basically these steroid precursors are being pushed more towards androgens than other things. And so in these patients, we're going to see an increase in androgens, which can cause similar masculinization features. However, in congenital adrenal hyperplasia with 21 hydroxylase deficiency, is we can get of steroid precursors. So we know that steroid precursors go get masculine, the fundamental imbalance that's occurring here because of our lack of aromatase. Now, I want to do some important differential building for you guys here because there are other conditions in which we get masculinization of the infant. And one that's important to talk about is congenital adrenal hyperplasia. Now, this is a variety of disease processes, which we're not going to get deep into, but essentially there is faulty shunting of steroid precursors. So we know that steroid precursors go on to make a variety of molecules. Some that we want to mention are things like androgens and estrogens and aldosterone and cortisol. And so what happens is we can get differential shunting of these molecules in congenital adrenal hyperplasia. One specifically is called 21 hydroxylase deficiency. And this is going to cause an increase in androgens because basically these steroid precursors are being pushed more towards androgens than other things. And so in these patients, we're going to see an increase in androgens, which can cause similar masculinization features. However, in congenital adrenal hyperplasia with 21 hydroxylase deficiency, we would also expect to see decreased aldosterone because of the abnormal shunting, which would cause decrease in blood pressure and increase in potassium. And we would also expect to see decreases in cortisol. And this is a great way to separate it from aromatase deficiency, which is only going to show the masculinization features without those additional blood pressure, potassium, cortisol findings. Let's move on now to talk about Kallmann syndrome, which is going to be another disorder of sexual development. And in Kallmann syndrome, it's all going to be about our GnRH neurons and their failure to migrate to the hypothalamus. So if we do a little bit of drawing here in our master diagram, I'm going to outline our hypothalamus right here. And this is going to be in close connection with the pituitary gland. And it also happens to be really close to our nasal structures. So I'm going to go ahead and draw in a nose here as well to show you guys that this is very close to where our nose would be. And sorry for my drawings, they are a little bit shoddy, but you guys get the picture here. And there's some important structures that I want to add into our diagram here, namely the olfactory bulb. So here's going to be our olfactory bulb, and what it does is it is responsible for a lot of our sensation of smell. Now, interestingly, there are GnRH neurons. And so these neurons are going to be responsible for gonadotropic activity. And normally these neurons take a nice little path from the olfactory area called the that exists in the hypothalamus. So let's just review that pathway here. We go from olfactory bulb to the preoptic nucleus. And essentially what happens here is this migration is failing to happen in these patients. So this pathway somehow gets interrupted and we get that failure of migration of GnRH neurons. These GnRH neurons are important because they're going to be responsible for a lot of gonadotropic activity. So we have failure to stimulate gonadotropic hormones. Essentially, the hypothalamus will not be releasing any GnRH, or if it's releasing some, it will be very small amounts. And we like to call this hypogonadotropic hypogonadism. And we talked about hypergonadotropic hypogonadism in our cases of Klinefelter's and Turner syndrome. This is different. In these cases, we do not have very many gonadotropins at all, which is why this is considered hypogonadotropic. And so our gonads are actually operating just fine. So you'll remember our gonads, which were our gamete makers, our testes, and our ovaries. In Kallmann syndrome, there's essentially nothing wrong with them. It's failure up here in the axis of the pituitary and the hypothalamus, and their inability to produce gonadotropins because we had that abnormal migration. So if we were to look at our labs here of a hypogonadotropic hypogonadism, we would expect to see decreased GnRH. This is our primary insult. We cannot make GnRH in the hypothalamus because we had failure of those neuron migrations. So that's going to lead to decreased FSH, decreased LH, and therefore that's going to cause decreased testosterone and decreased estrogen. And this is going to be the classic lab values for a hypogonadotropic hypogonadism. So let's talk about how this is going to present based on the pathophysiology we just discussed. We're going to have lack of secondary sex characteristics in these patients. And this makes sense, right? Because at the end of our pathway here, we have decreased testosterone and decreased estrogen, and we know that those are important for development of these secondary sex characteristics. Next on our list is going to be primary amenorrhea, and this also makes sense because we know that estrogen is going to be necessary for menses. We talked about that up here when we were talking about aromatase deficiency, and so the same physiology is going to apply to Kallmann syndrome. Next on our list, we have decreased sperm count, and this also tracks because we know that sperm maturation and sperm production is going to be heavily dependent on levels of testosterone, which in this condition are low. So let's talk about cryptorchidism. In previous videos, we discussed how the path of the testes from the retroperitoneal space down into the scrotum is heavily dependent on testosterone. We have low testosterone in this condition, and so that migration is going to get interrupted. We can get cryptorchid testes here, and these need to be manually placed back in the scrotum with orchiopexy in order to prevent testicular cancer. Next, let's talk about the fact that these patients are going to have decreases in height, and this makes sense because when we don't have release of FSH and LH, it's like we never even went through puberty. And we know that puberty is an important time for growth. And so these patients, especially our male patients, are going to present with decreased height. So I want to make a note here that this is usually going to be in male patients where we see this because the male height development is heavily dependent on testosterone. And lastly, the most interesting finding here is going to be anosmia. And for those of you that don't know what anosmia is, it stands for lack of smell. And these patients are going to have lack of smell because it goes back to our discussion from our master diagram. So remember my really bad drawing of a nose here that you guys are probably laughing at? Well, that relates to why they have anosmia. So we talked about this red olfactory bulb, right? And that's where our GnRH neurons were supposed to migrate to the preoptic nucleus in the hypothalamus. Well, that's not the only thing that goes awry here. There are special neurons responsible for our sense of smell that also undergo some complex migration in this area, and that migration fails, and therefore these patients are going to have a really reduced or sometimes a lack of smell. And I cannot stress enough how high yield this is because you're going to get someone on exam day who maybe doesn't have periods or who has lack of secondary sex characteristics, and they report that they have difficulty smelling, and you're like, oh my gosh, this sounds like Kallmann syndrome. And then you can easily get that diagnosis right, and this will literally jump off the page at you guys. So let's wrap up with a high yield review here. When it comes to placental aromatase deficiency, it's going to be all about that combination of the fetal and maternal masculinization and relating this to the fact that they are lacking aromatase. We will not expect any of the additional findings of a congenital adrenal hyperplasia, so that's a great way to form differential here. On labs, we're going to expect decreased estrogen and increased testosterone. Moving on to Kallmann syndrome, it's all about this fancy migration in the axis of our nose, hypothalamus and pituitary. That migration fails. I would say it's important to know that's olfactory bulb and preoptic nucleus. Those tend to be hot words on exam day. We went through a lot of the findings here, and they're all going to be due to decreased levels of testosterone and estrogen. And then most important, be on the lookout for that anosmia, which is lack of smell. This is going to be so high yield in terms of recognizing Kallmann syndrome on exam day. I hope you guys enjoyed this one. All right, guys, let's get busy talking anatomy. We're going to start by talking about our organs, and we're going to take an embryological approach to this. So you guys will remember we have our testes, which are going to be formed from our gonadal ridge, and our testes are here, and they're going to contain our seminiferous tubules. And I'm highlighting this in brown because they're coming from the gonadal ridge. Moving on, we're going to talk about all the structures that come from our mesonephric ducts. I'm going to highlight all of these in orange for you. So remember, our mnemonic for the mesonephric duct structures is seed. So we're going to go ahead and start with our seminal vesicles, which I'm going to label up here, and they are responsible for producing a lot of the content of semen. Specifically, they are going to make alkaline material that is going to help sperm survive in the vagina. Next, let's talk about our epididymis down here, and that's this little guy that's hanging out on top of our testes, and this is going to be the site that is responsible for sperm maturation. So sperm leave our seminal tubules and they go up into the epididymis and hang out for a while and get nice and mature. This is where they achieve their ability to become motile, etc., etc. Next, let's talk about our ejaculatory duct. This is the next E in seed, and our ejaculatory duct is going to be this portion right here, and it is where the semen and the urine begin to mix, and this is going to occur in the area of the prostatic urethra, which we will talk a little bit more in a bit. And lastly, the last thing in our seed mnemonic is going to be our ductus or vas deferens, and that's going to be this section here, which I'm highlighting in orange, and this is going to connect the epididymis, where the sperm mature, to the seminal vesicles, where they're ready to go on their journey out into the world. So let's move on to talking about our prostate gland, which is going to be this that I'm highlighting here in blue, and the prostate gland is going to have two portions. It's going to have an anterior portion, which is going to be where we get benign prostate hyperplasia occurring, and it's going to have a posterior portion, which is quite glandular. It provides a lot of secretions necessary for proper semen and also helps with lubricating the urethra, and this posterior section is going to be more prone to cancer. So it's important to know on test day the difference between what happens in the anterior and posterior regions of the prostate. Let's wrap up by talking about the penis, which is going to be highlighted down here in red. And I want to talk about various portions of the penis. Remember that the penis comes from the genital tubercle, and here in the pink area that I'm outlining here on the lateral sides, this is going to make the corpus cavernosum. And then in this orange portion that I'm highlighting, this is going to be the corpus spongiosum, and it's going to be the urethra that runs through the center of this corpus spongiosum. So let's imagine if we were to take a cross section here of our penis along its shaft, what would it look like? And if we zoom in here to get a better look at this cross section here, we're going to see we have the corpus cavernosum, which was our pink structure, and then we're going to have our orange corpus spongiosum with our urethra running through the middle. And additionally, there's going to be some important fascial structures which will relate to some pathology we discuss in a bit. So here around the penis proper, we have Buck's fascia, and then a little further out, we have Dartos fascia. And Dartos fascia is going to wrap around both the penis and the scrotum. So hold this into your mind because I want you to think about it later on when we talk about some pathology. So let's go ahead and zoom back out and let's move our discussion to talking about parts of the urethra. So let's start out with the prostatic urethra, which we're going to highlight in blue. So it's going to run down here through the middle of the urethra, and the prostatic urethra is the portion where our semen and our urine are going to combine and go through the urethra and out into the environment. Our next part of our urethra is going to be the membranous urethra, and it's this little part right here, and it happens to be the thinnest part of the urethra, so it's going to be really prone to injury when we are catheterizing patients, and this happens to be where there's like a nice little bend in the tissue of the penis, and so if you like jam something in there really fast, it's going to damage that membranous urethra. Moving on in green, we're going to talk about the bulbar urethra, and that's this beginning portion of the urethra here in the penis. And this is going to be prone to a type of injury as well that we're going to discuss later. So keep an eye out for that. And finally, this last part of the urethra is going to be the penile urethra, which I'm highlighting here in red. And this is the last part of the urethra as it exits out into the environment. This is where we're going to be able to see the urethral meatus, which is this tip part of the urethra. And sometimes we can see blood or discharge coming from that area, and so it's an important one. Let's do a quick review of the structures we talked about and where they come from. So our testes are coming from our gonadal ridge, and then we have our seed structures, our seminal vesicle, ejaculatory duct, epididymis, and ductus deferens coming from our Wolffian or mesonephric duct. And then we talked about the prostate, which comes from the urogenital sinus. And finally, we have our penis, which is going to be a combination of our urogenital fold and our genital tubercle. Before we move on, I want to talk about the pathway of both semen and the pathway of urine. So in our pathway of urine, we're going to be tracing along the urethra, so prostatic, membranous, bulbar, and penile. Whereas in the case of our semen is going to take the path of a mnemonic called 7-up. So 7-up is going to stand for seminiferous tubules, epididymis, vas deferens, ejaculatory duct. N stands for nothing, so I just put a little smiley face there. And then U is our urethra, and P is going to be our penis. So if we follow this path, we're here in our seminiferous tubules, we go up here to the epididymis, and then we're going to come down to the vas deferens, which goes all the way up, and it's going to go through our ejaculatory duct, and then it's going to come down here through the urethra and exit out at the tip of the penis. Now, urine, on the other hand, is going to come from the bladder up here and down the urethra, and remember, we're going to have combination of this in the prostatic urethra, and that's going to be key, an area of mixing point. I like to think of the prostate as a big mixing bowl for all of our substances on their way out the penis. Let's move on now to talk about blood flow of our male reproductive anatomy. So here we have our big aorta and our big inferior vena cava. Let's talk about arterial supply first. So arterial supply to the testes is going to occur from our testicular arteries, which are going to branch directly off the aorta and go to the right and left testicle. Now, when we talk about venous supply, this is where it gets a little bit tricky. So here's our inferior vena cava, and you'll notice we have our right renal vein serving the right kidney and our left renal vein, which is going to serve the left kidney. Now, you'll notice something different here. Look at this right gonadal vein. It's coming directly off the inferior vena cava, and you'll notice that this left gonadal vein is coming off the left renal vein. So it's coming off of a renal vein, whereas this one's coming off the vena cava. That's kind of different, and it's actually quite important. And so you'll notice here that we have our left renal vein that comes all the way across the aorta, and it has to slip under this superior mesenteric artery. This is a really convoluted path. And so I want to talk about something called nutcracker syndrome, which is all about this superior mesenteric artery. Now, you may be seeing these smiley face guys and like, Jake, why are you drawing smiley faces all over this video? And these smiley faces represent fat pads. And these fat pads normally hold up our superior mesenteric artery, and it allows this left renal vein to course under there rather uninhibited. However, in the case of cancer or severe weight loss, these fat pads can get displaced. So let's imagine we had a malignancy that's coming in here and being really mean, and it's kind of disrupting this architecture temperature of the fat pad, that could make it go away. Or if someone has severe massive weight loss, like they got a gastric bypass or some sort of weight loss surgery, they can rapidly lose these fat pads, and then our superior mesenteric artery is going to fall down and it's going to trap this left renal vein. And so what happens in this case is this kidney is going to be really backed up. It's not going to be able to get its blood back to the inferior vena cava. And so you're going to see things like hydronephrosis and kidney failure, maybe some hematuria. But additionally, we're going to have some things going on with the left gonadal vein. Specifically, we're going to get a pathology that is called varicocele. And this is going to be described like a sac of worms within the scrotum. And this is because we have massive backflow of blood. So remember, we have a backflow here and it's going to push back here, but it's also pushing down the left gonadal vein. And so you're going to get a bunch of blood trapped down here in the scrotum, and it's going to present classically like a bag or a sack of worms. That's how they love to talk about this on test day. And it's usually going to be a guy who comes in, he's like, hey, like, I have this like weird sack of worms in my scrotum. And that's something they like to ask about. And then also they like to say that varicocele is going to cause infertility because we have all that extra blood in our scrotum, and that really heats up the scrotum, makes it warm. And we know that our sperm maturation is temperature dependent. And so our Leydig cells, our Sertoli cells, are not going to like those high temperatures. And so that's another thing that they like to ask in terms of like third order questions here. Let's zoom out now and review our blood flow. So we're going to have our testicular artery that comes off the branch of the abdominal aorta. It's going to come off the abdominal aorta on both the right and the left side. And additionally, we're going to have some other portions of our male reproductive anatomy supplied by the internal iliac branches. However, these are low yield, so we don't need to go into the specifics of them. What we do need to talk about specifically is the venous supply, right? So we talked about the fact that the left renal vein can become trapped, and that's going to cause backward blood flow and lead to things like varicocele or hematuria and kidney failure and things like that. So that's going to be all due to our backward blood flow. And this is largely going to occur primarily on the left side in vignettes because that right side comes directly into the inferior vena cava, whereas the left side has a more convoluted path through the left renal vein. And remember, we like to call this nutcracker syndrome. And in terms of symptoms, left varicocele, hematuria, flank pain, and our causes are going to be things like renal cell carcinoma or intense weight loss. And we talked about that with our fat loss guys. And then there are also going to be a pampiniform plexus, which is a venous plexus that has like lacy reticular veins all throughout the pelvic plexus. That's going to allow blood flow back up into the inferior vena cava as well. Let's move on now to talk about some lymphatic drainage. This is rather high yield on the exam. They love to ask about this, and this is due to embryology. So we know that our testicles are going to be a retroperitoneal structure, and so they're going to be quite deep, and their lymphatic supply also follows their path down from the retroperitoneum down into the scrotum. So in terms of the testes, it's going to be our para-aortic nodes that are going to supply the testes. And I put these in our drawing here, right along here, which I'm highlighting in green. So these nodes are right along the aorta, and this is what needs to be biopsied if we're like suspecting a testicular cancer or something of this sort. We also have some other lymphatic drainage from our scrotum. I'm drawing it in this like light green color because I consider light green like a superficial light color. So we have superficial inguinal nodes to our scrotum because the scrotum is really superficial structure. And I'm going to use this darker green color to talk about the prostate and the corpus cavernosum, which are going to drain to our internal iliac nodes, which makes sense because they're internal structures. So they're going to drain to an internal node. That's why I'm using this dark, deep green internally. Let's move on now to talking about this sexual response, which is going to be how males develop erections and eventually ejaculate in the act of intercourse. And don't worry, I kind of reset some of our colors here in our diagram, but that's just so we can get a better look at some of these structures that are coming up. So let's go ahead and get started on the sexual response by talking about a mnemonic. And the mnemonic here is point, squeeze, and shoot. So let's walk through this mnemonic, starting with erection. It's going to be all about pelvic parasympathetic nerves, and you're going to see here that I have this highlighted in orange, and so that is the point portion of our mnemonic. And it's important to also note that during the erection period, this is going to be due to blood flow that's going to be filling the corpus cavernosum, and some drugs that we talk about in relation to treating erectile dysfunction are going to be PDE5 inhibitors such as sildenafil. So that's something to be aware of in relation to erectile dysfunction. So let's move on now to talk about squeeze, and squeeze is going to be all about emission. So remember when we followed our blue path of sperm all the way here, this is the squeezed portion. It's getting that sperm up and down to the prostate and into the urethra. And this is going to be due to the hypogastric nerves, which are sympathetic in origin. And then finally, we're going to have shoot. And shoot is going to be due to pudendal nerves, which are going to be somatic. And this is actually going to be clenching down to force that semen out into the environment in order to facilitate reproduction. Let's move on now to talk about our urethral injuries. We're going to have two types of urethral injuries. We're going to talk about anterior first and posterior second. But let's quickly do a review of our urethra because it has a lot of parts. So remember, we have our blue prostatic urethra, which is here. We have our pink part, which is the smallest and narrowest part, which is our membranous. And then we have our green bulbar urethra and then our red penile urethra. So after that quick review, let's go ahead and get into our anterior urethral injuries, which are going to be due to damage to the bulbar urethra, which remember here is this green portion that we just talked about. And this is going to be most common in straddle injuries. So you're going to think of like a skateboarder who's like trying to do a mad trick and he like straddles his legs over like a bar. That is the classic person who's going to get this type of injury. And our presentation here is going to be blood at the urethral meatus as well as a scrotal hematoma. And let's talk about more about how this happens by looking at our little cross section here of our penis. So you'll notice here that here's our cavernosal artery. It is what supplies blood to our penis. And then we have our urethra, which is covered by our corpus spongiosum. And essentially what happens here is we get trauma here. And then when it comes to blood from that trauma, that blood is going to start leaking out and filling up this penile cavity. And then this penile cavity is lined by Buck's fascia. And so what happens is if we get a rip in Buck's fascia from this traumatic injury, which is what happens, then this blood is going to leak out and it's going to leak out into this area here. And what happens is that this area is confined by dartos fascia, and dartos fascia is actually going to go all the way down to the testicles, which I'm like kind of labeling here off to the side, and the scrotum. And so that's why we get a scrotal hematoma, because it's dartos fascia that is holding all this blood and kind of channeling it down towards the scrotum, which is why this anterior urethral injury bleeding leads to scrotal hematoma. Zooming out now, let's talk about our posterior urethral injury, and this is going to be damage to the membranous urethra. And let's refresh ourselves. Our membranous urethra is this really thin part here that is really, really small. And so you're asking like, okay, that looks like it's a pretty deep structure. Like, how are you going to damage that guy? And the answer here is going to be pelvic fractures. So when we have people in like